So let's move on to the next case presentation. Measles associated retinopathy. I invite Dr. Swapnil Parchand. 6 minutes, sir.
Thank you, ma'am. So I'll be presenting two cases of measles associated retinopathy. So this is the first case. He's 20-year-old male and he complained of sudden loss of vision in right eye since 1 month, and he has history of hemiplegia 1 month back and was admitted at tertiary care multi-speciality hospital. Vision in right eye was PR present, PR inaccurate. There was RAPD, and this was the images which was sent to me by the referring ophthalmologist. This image was taken with a smartphone. So she said that there is a picture of CRAO, but she could not explain the hemorrhages which were there at the center, and OCT was not correlating with the diagnosis of CRAO. So in this picture we can see that there is pale disc, there is arterial attenuation, there is retinal opacification, and in center there are few scattered hemorrhages. And on OCT you can see that whole retinal architecture is distorted. There is moth-eaten appearance of the retinal tissue, and the characteristic finding which you can see is the ILM is intact and there is ballooning of ILM. So this was the picture when this patient presented to us. So you can see that this picture was after 1 week of the last images. So there is this disc pallor, and there is arterial attenuation, and the normal sheen of the retina is lost. There are these Kesey's cavities, and there is the scarring at the fovea. So this was the angiogram. There was hypofluorescence, and which remained hypofluorescence in the late phase. And this was the OCT which was done by us. Again, you can see that ILM is intact. The retinal architecture is destroyed, and there are these Kesey's cavities. This is left eye. Left eye was absolutely normal. And this MRI, he had this MRI report, so which showed that there is altered signal intensity in right temporal lobe, right basal ganglia, reaching up to genu of the internal capsule, and it is involving extending till caudate nucleus. And most importantly, it was showing that it is predominantly involving the white matter, and the gray white matter was differentiated, it was maintained. So since we had this OCT images with ILM ballooning intact ILM, we advised measles serology, and the IgG for measles was high and it was positive. And on retrospective history, he did give history of measles during childhood, and this patient was further referred back to his multi-speciality hospital for the treatment. This is case 2. He is a 30-year-old male and he complained of sudden loss of vision in right eye. This patient gave history of measles at the age of 5 years. At presentation, in vision in right eye was counting finger 1 meter. Again, he has RAPD. Left eye was normal. This was the fundus picture at presentation. You can see that the media is fairly clear. There was no vitritis. Disc was normal. There was this area of retinal opacification which was centered around the fovea, and there was this another PD like retinitis lesion. Left eye was normal. This is in high magnification. You can see this yellowish white area of retinal opacification which is clearing in the nasally with some scarring. So again, angiography showed some subtle leakage in the nasal part of this lesion, and OCT again showed this ballooning of ILM, and there is ILM is intact. There is hyperreflectivity involving the inner retinal layers and this Kesey's cavities. So again, in this patient, the measles titer were raised, serum as well as CSF titer were also quite raised. But interestingly, he did not have any CNS clinical. It was normal. MRI was normal, and EEG was also normal. And this patient was advised interferon therapy, but he did not agree for the treatment and lost to follow. So to discuss, if we see the diagnostic criteria of SSP, it actually lacks the ocular finding. But if we see, almost 50% of the patient of SSP has some form of ocular involvement. Most of this patient have bilateral one eye followed by the other. And most characteristic involvement of measles associated retinopathy is involvement of the macula, which might be in the form of, it can have various presentation. It can have macular chorioretinitis, it can have retinal edema, retinal folds, or hemorrhagic retinitis. And in late stage, all leaf macular pigmentary disturbances. So if the patient only have this ocular feature, it might be difficult to diagnose in the absence of SSP. But this is something a very important sign on OCT, which we can see, that is there is total disintegration or necrosis of the retinal layers, but it spares the ILM and Brooks membrane, and most importantly it shows ILM ballooning. And subsequently, if we do anti-measles antibody, so they are a diagnostic of SSP. So the last case we did publish in Ocular Immunology and Inflammation, and our co-author was Dr. Parthopratim sir. So that was about measles associated retinopathy.
Thank, thank you, Swapnil. Can Dr. Partho comment? He's ready.
Thanks, Swapnil. Very nice case. Actually, this case, when Swapnil sent to me, there was a little bit of challenge in this, because the neurologist, when you refer this patient to such patient to neurologist, they follow the Daikin criteria. So now the Daikin criteria says that there are five criteria. Like, one is your behavioral changes. The number two is EEG characteristic, EEG changes. And then there is a CSF globulin level, CSF antibody for the measles, and the fifth one is your brain biopsy.
Right.
So if you follow these patients, there was patient did not have any behavioral changes, EEG was normal, and so the neurologist was reluctant to do the CSF tap. So I convinced him, saying that, sir, please do the tap, because the OCT picture is so characteristic of measles retinopathy, kindly do that. So finally he agreed, and everything was globulin, CSF globulin was raised, CSF antibody titer was raised, and they also presented in their meeting and discuss about that. So I think the moral of the story is that you have to, if you are clinically suspecting that measles retinopathy, you have to talk to your neurologist, because they follow the Daikin criteria, and sometimes it is not all the criteria are not actually fulfilled in these cases. So only based on the clinical suspicion, you should talk to the neurologist and convince them to do the CSF tap.
Only concern is that after the measles, 6 to 7 years, there is a SSP can occur. Now, in this situation, is there any marker that can tell you that the patient may develop SSP? Or we all in India, we are vaccinated with MMR vaccination in our childhood. Is there a role of secondary vaccination in these cases? Because there is a optic nerve changes have already happened in this patient.
Yeah, thanks for the comment, Dr. Dipankar.